Welcome to the deep dive. Ever feel like your own body is working against you? Today, we're plunging into a condition where that's, well, precisely what happens: Hashimoto thyroiditis.
Hmm.
This isn't just a quick rundown of symptoms. We're aiming this at you, the curious mind wanting to really grasp the details of this common, yet pretty complex condition.
Yeah, there's a lot to unpack.
We've gone through the medical sources, trying to pull out what really matters, our mission, to get our heads around the what, the why, how it actually shows up, and what it means for people living with Hashimoto's.
It's a really interesting area. Hashimoto thyroiditis, at its heart, it's an autoimmune disorder.
Okay.
You can think of it like a case of mistaken identity, where the body's own defense system,
Yeah.
it launches this sustained inflammatory attack specifically on the thyroid gland. And what's really notable is that in places where people get enough iodine in their diet, this is actually the single most common cause of hypothyroidism.
So our body's security force basically gets its signals crossed and starts attacking, well, its own command center.
Exactly. The immune system incorrectly sees the thyroid gland, which is, vital for metabolism. It sees it as foreign. That misidentification is really the core issue in Hashimoto's.
And we've known about this for a while, haven't we? This isn't some brand new discovery.
Oh, definitely not. Our understanding goes back well over 100 years. The condition's named after Dr. Hikaru Hashimoto. He described it meticulously back in 1912.
Wow, 1912. So a long history there.
A very long history of medical digging behind what we know now.
Okay, so this internal attack is happening. But, what's going on at the cellular level? How does the immune system actually attack the thyroid?
Right. It's sort of a two-pronged attack, if you will. First, you have specific immune cells called T cells, and they directly target and damage the thyroid's functional cells.
Okay, direct assault.
Yep. And at the same time, the body starts producing antibodies. These are specialized proteins that latch onto really key thyroid components, mainly thyroid peroxidase, TPO, and thyroglobulin. And these antibodies, they basically act like flags, marking the thyroid for further immune destruction.
So the T cells are like the ground troops, maybe? And the antibodies are the air support, both zeroing in on the thyroid?
That's actually a pretty good analogy.
Yeah.
And this sustained assault, it leads to something called lymphocytic infiltration.
Okay.
Imagine like an army of these immune cells, mostly B and T cells, just building up inside the thyroid tissue.
Mm.
And this infiltration is often accompanied by fibrosis, that's basically scar tissue forming. Over time, this whole relentless process can lead to thyroid atrophy. The gland actually shrinks.
And the unavoidable outcome of all this fighting is the thyroid just can't make enough hormones anymore.
Precisely. That gradual loss of working thyroid tissue means less output of thyroid hormones, and that lack of hormones is what we call hypothyroidism.
Okay. Now, who tends to get this? Are there, specific groups more likely to develop Hashimoto's?
Yeah, the data shows some pretty clear risk factors. One of the most striking is the gender difference. It's significantly more common in women.
How much more common?
Well, the reported female-to-male ratio is around 10 to 1.
10 to 1. Wow, that's huge.
It really is. It's a key demographic, and researchers are still exploring why things like hormones may be X chromosome factors.
Okay, 10 to 1. What about age? Is there a typical time it shows up?
It can happen at any age, really, but Hashimoto's is most often diagnosed between, say, 30 and 50 years old.
And our genes, does family history play a part?
Absolutely.
Yeah.
Genetics are definitely involved. If you have a family history of other autoimmune conditions like type 1 diabetes, lupus, rheumatoid arthritis, your risk of Hashimoto's is higher.
So there's a sort of general autoimmune susceptibility link there.
Exactly. It suggests a shared genetic tendency towards autoimmunity.
And beyond our genes, what about environmental factors? Things outside us that could trigger it?
Well, several environmental factors have been linked. Too much iodine intake is one, which is interesting, right?
Mm.
Even good things can be complex.
Yeah.
Radiation exposure is another known risk. And also certain viral infections like hepatitis C and Epstein-Barr virus, they've also been implicated.
So maybe a virus could sort of kickstart the process in someone who's already susceptible.
That's one leading theory, yes. It could push a susceptible immune system over the edge. And adding to that, we see Hashimoto's more often in people who already have other autoimmune conditions, like celiac disease, Addison's disease, vitiligo. It reinforces that idea of a broader autoimmune vulnerability in some individuals.
Right. So someone might have this process starting inside them for a while without realizing it. What are the first clues? The initial signs something's off?
Yeah, the initial stages can actually be a bit confusing. Some people might go through a phase called hashitoxicosis. Yeah,
Hashitoxicosis.
and paradoxically, they might get mild hyperthyroid symptoms.
Wait, hyperthyroid? But isn't Hashimoto's the main cause of hypothyroidism? That sounds backwards.
It does. It seems counterintuitive. But in this early phase, as the thyroid cells getting damaged, they can leak stored thyroid hormones into the blood.
Ah, like a release valve opening up temporarily.
Kind of.
Yeah.
And that temporary surge can cause symptoms like fatigue. Yes, even fatigue can be part of it, but also weight loss, palpitations, feeling hot all the time. It's like the thyroid briefly flares up as it breaks down before function really declines long term.
So, a temporary spike before the eventual drop. What happens then as it progresses?
As more and more of the thyroid tissue gets damaged by the autoimmune attack, well, that's when the more classic picture of hypothyroidism starts to emerge.
And those are the symptoms we usually think of with an underactive thyroid, right?
Like the classic ones are that persistent fatigue,
Hmm.
maybe gaining weight without changing habits, feeling cold when others are comfortable.
Yeah.
But the list can be pretty long. People might also notice dry skin, brittle nails, hair loss, constipation, muscle weakness, joint pain, even depression, trouble concentrating, memory issues.
Wow, that's a whole range of things. It sounds like it could be easy to blame those on stress or just getting older.
It absolutely can be,
Hmm.
which is why diagnosis sometimes takes a while.
Yeah.
Another physical sign that can crop up is a goiter. That's an enlargement of the thyroid gland in the neck. It usually feels firm, kind of rubbery, and typically isn't tender or painful.
Okay.
And then in really severe, long-standing cases of hypothyroidism, a more advanced condition called myxedema can develop.
Myxedema. That sounds serious. What is that exactly?
It is serious. Myxedema is basically a very severe stage of hypothyroidism where the body's functions slow down significantly. It's actually a medical emergency that needs urgent treatment.
Okay, so if someone's noticing some of these signs, how do doctors figure out if it's Hashimoto's? What tests are involved?
Blood tests are absolutely key here. Really fundamental. The first step is usually checking thyroid function tests, or TFTs. We're mainly looking for an elevated level of TSH, thyroid stimulating hormone. TSH comes from the pituitary gland, telling the thyroid to work.
Oh.
If the thyroid is failing, the pituitary shouts louder, so TSH goes up.
Okay, high TSH is a big clue.
It's the primary indicator.
Yeah.
Then we look at free T4, the main thyroid hormone. If TSH is high and free T4 is low, that confirms overt hypothyroidism. But you can also have what's called subclinical hypothyroidism.
Subclinical.
Yeah, where the TSH is high, showing the thyroid is struggling, but the free T4 level is still technically in the normal range. It might be an earlier stage.
And those antibody tests you mentioned earlier, they must be important too.
Oh, absolutely crucial pieces of the puzzle. Finding specific thyroid antibodies strongly points to an autoimmune cause. Anti-TPO antibodies, it's anti-thyroid peroxidase, they're positive in like 90 to 95% of cases. Very high percentage.
Wow.
And anti-TJAG antibodies, antithyroglobulin, are also found pretty often, maybe 60 to 80% of the time. These are really key diagnostic markers.
Are there other things in the blood work that might hint at it?
Sometimes, yeah. For instance, cholesterol levels might be elevated because of the underactive thyroid, or sometimes anemia can show up too, either normocytic or macrocytic type.
What about imaging, like an ultrasound? Does that help?
Imaging can definitely provide supporting evidence. A thyroid ultrasound often shows characteristic features. The tissue might look hypoechoic, darker than normal on the scan, and heterogeneous, meaning uneven, sometimes with things called pseudonodules.
Okay.
Blood flow, the vascularity, can also change depending on the stage, might be higher during inflammation, lower later on. There's also a radioactive iodine uptake test, or NRAIU.
What does that show?
It checks how much iodine the thyroid takes up. In Hashimoto's, the results can vary a lot, reflecting that sort of changing activity level of the gland.
And if, for some reason, a biopsy of the thyroid is done, what would pathologists see?
Right. If they look at the tissue under a microscope, histopathology, it can give a definitive confirmation. They'd see that lymphocytic infiltration we talked about, those immune cells packed in there, along with something called Hürthle cell changes and fibrosis, the scarring.
So it sounds like it's mainly the blood tests, TSH, and antibodies, plus maybe an ultrasound that clinches the diagnosis usually. Now, what else could cause similar symptoms? What do doctors need to rule out?
That's a really important question, the differential diagnosis. We need to make sure it's not hypothyroidism from other causes, like maybe someone had their thyroid removed surgically or had radioactive iodine treatment for being hyperthyroid before.
Right.
Iodine deficiency can also cause it,
Oh,
though
yeah.
less common in many parts of the world now. And then You have to distinguish Hashimoto's from other types of thyroiditis.
Such as?
Well, there's subacute thyroiditis decurvens. That one's often painful in the neck, maybe after a virus. There's postpartum thyroiditis, which happens after childbirth, often with a temporary hyperphase, then hypo.
Ah,
Silent thyroiditis is another painless one, can also have that temporary hyperthyroidism.
yeah.
And critically, you have to differentiate it from Graves' disease.
Graves, that's also autoimmune, right, but different.
Exactly. Graves' is also autoimmune, but it causes hyperthyroidism and overactive thyroid, usually with diffuse goiter. Opposite effect.
So the symptoms and the specific test results, especially the antibody patterns, help sort these out.
Precisely. It's about putting all the pieces together.
Okay, so let's say someone gets the diagnosis, Hashimoto thyroiditis. What's the plan then? How is it managed?
The main strategy, once it causes hypothyroidism, is hormone replacement. We replace the missing thyroid hormone with levothyroxine.
Levothyroxine, that's synthetic T4, right?
That's right. It's the synthetic version of the main hormone a healthy thyroid makes.
And how do you figure out the right dose for someone? Is it one size fits all?
Oh, definitely not. The starting dose is usually based on weight. Roughly 1.6 micrograms per kilogram per day is a common starting point. But that's just a guideline. The really crucial part is adjusting the dose based on regular TSH blood tests. The goal is to get the TSH into the optimal range for that specific person and keep it there.
Are there people who need to start more cautiously, like lower doses?
Yes, absolutely. For older adults or people with known heart conditions, we usually start with a lower dose, maybe 25 or 50 micrograms a day, and increase it very gradually.
Why is that?
Just to avoid putting any sudden strain on the cardiovascular system as the metabolism speeds back up. A gentler start.
Makes sense. And how often do people need those TSH checks when they first start?
After starting levothyroxine or changing the dose, TSH is typically checked every 6 to 8 weeks. Once the dose is stable and the TSH is consistently in the target range, then checking it once a year is usually enough for most people.
What about T3, the other thyroid hormone? Is synthetic T3 liothyronine ever used?
It's not common practice. Liothyronine isn't routinely used for Hashimoto's related hypothyroidism. While, some people still feel unwell despite having a normal TSH on levothyroxine, adding T3 is pretty controversial and usually only considered in very specific cases under specialist care.
Okay, so mainly levothyroxine. What about other things? Does the goiter ever need treatment?
Sometimes the levothyroxine treatment itself can help shrink the goiter, but surgery, a thyroidectomy, is needed occasionally.
When would that happen?
Usually if the goiter is causing significant compression symptoms like trouble swallowing or breathing, or if it's very large and causing cosmetic concerns, or if there's a nodule within the thyroid that looks suspicious for malignancy. But surgery is relatively rare for Hashimoto's itself.
And even when someone feels stable on their medication, ongoing monitoring is still important.
Definitely. Those annual TSH checks are vital to make sure the dose is still right. And because people with one autoimmune disease are at higher risk for others, doctors also keep an eye out for any new symptoms that might suggest something else is developing.
Okay. What happens if Hashimoto's isn't treated or isn't managed well? What are the potential long-term problems?
Untreated Hashimoto's can lead to progressively worse hypothyroidism and its complications. In really severe, though rare, situations, it can lead to that myxedema coma we mentioned, which is life-threatening and needs immediate hospital treatment.
Wow.
Also, chronic hypothyroidism can increase the risk of cardiovascular problems, partly due to effects on cholesterol levels. And for women, it can impact fertility and raise the risk of miscarriage.
And you mentioned the link to other conditions earlier. Anything specific people should be aware of?
Yes, there's a slightly increased risk, though still low overall, of developing thyroid lymphoma in people with Hashimoto's. And it's good to be aware of the association with things like pernicious anemia or celiac disease. Doctors might screen for those if symptoms suggested.
But overall, with treatment, what's the general outlook? The prognosis?
Generally speaking, the prognosis for people with Hashimoto's is excellent, provided they stick with lifelong levothyroxine therapy. It is a chronic progressive condition, yes, but the symptoms of hypothyroidism are usually managed very effectively with the medication. Most people can live completely normal, healthy lives.
What about pregnancy? Are there special considerations for women with Hashimoto's who want to conceive or are pregnant?
Yes, pregnancy needs really close management. The target TSH level during pregnancy is usually lower, stricter, often below 2.5.
Okay.
And the levothyroxine dose often needs to be increased during pregnancy, maybe by 25 to 30%, sometimes more, to make sure there's enough thyroid hormone for both the mother and the developing baby. So very careful monitoring is essential throughout pregnancy.
Right. Finally, then, what are the absolute key things someone living with Hashimoto's needs to know for managing it well day to day?
Patient education is just so important.
Huh.
Number one, understanding that taking the levothyroxine medication consistently, as prescribed every day, is crucial. It's lifelong.
Okay. Lifelong adherence.
Number two, learning to recognize the symptoms of both undertreatment, those hypothyroid symptoms coming back, and overtreatment.
Overtreatment, like what?
Overtreatment can make you feel hyperthyroid, maybe anxious, shaky, rapid heartbeat, losing weight unexpectedly, feeling too hot. So knowing the signs both ways.
Got it. Check for too little or too much effect.
Exactly. And number three, knowing how to take the levothyroxine correctly. It works best on an empty stomach, usually 30 to 60 minutes before breakfast. And being aware of things that interfere with its absorption, like calcium supplements, iron, some acid reflux meds called PPIs, even soy products. Spacing those out is important.
So take it consistently, know your symptoms, and take it correctly away from things that interfere. That sounds like the core message.
That's it. Empowering people with that knowledge makes a huge difference in managing the condition effectively and just feeling well.
So to wrap this up then, Hashimoto thyroiditis. It's an autoimmune attack targeting the thyroid, usually causing hypothyroidism. Diagnosis relies heavily on blood tests, TSH, and antibodies, and management is centered around lifelong levothyroxine replacement. Understanding all these bits is really key for anyone affected.
Absolutely. And, thinking about it, it's pretty amazing how our immune system, which is meant to protect us, can sometimes get confused and attack our own body. This whole dive into Hashimoto's really underscores that delicate balance inside us. And maybe it sparks a bit more curiosity in you, the listener, to explore the fascinating, complex world of autoimmune disorders further.
Thanks for diving deep with us today. Until our next exploration.